Very warm welcome to this surgery online. Today we are going to talk about bone bridge implant surgery in children with complex ear disease, microtia and aural atresia. And first I want to start why we believe that bone conduction implant in children is something special. Because children are active, so they need an implant that is that is safe for impact. And with the bone bridge, we have a recessed design and a robust fixation. And what I mean by this, I want to show you. So the recessed design means that we drill a bed and recess the implant so it's safely embedded in bone. And like this, it has low leverage forces on the implant body. And with the proven BCI fixation, we have a standard 2-point fixation. We have no leverage forces on the screws. And also, we do not rely on osseointegration for stability. Then, children have very thin skin. So they also need an implant that is safe for the skin point of view. And we try to have a very ergonomic design of the implant body so that we have less protrusion. And if you look at the CT scan that was published in a Nature journal, you see how nicely the BCI is recessed in bone and like this little protrusion into the skin. So there is low skin stress. On the other hand, our competitors, they have a top-mounted design. And by this, you put on top of the screw, you put the transducer, and like this, it is much higher and there is a higher skin stress then. And especially in children who have thin skin, this is a really important issue. Then, children have a smaller anatomy and often they have a very difficult anatomy. So it is good to have a smaller footprint overall and also to have surgical flexibility. And by the ability of bending the implant transition, you can have the BCFMD wherever you find enough bone and to have the coil in the position where you want to have the audio processor so that you have good sound transfer. And in addition, we also offer BCI lifts so that you can elevate the implant a little bit in case you encounter some difficult structures. And then last but not least, there is also Otoplan available now for the BCI 602. This is a CT analysis that can be done very easily by showing green that there is enough bone, and if it's red, there is not enough bone. So with this, you very easily and quickly can check where to place the BCFMT. And for children, also important is you need an implant that is MRI safe because, or conditional, sorry, because you need, the children will need a surgery or an MRI during their lifetime. And with the BCI 602, children can have at 1.5 Tesla an MRI scan because we have magnets that are designed specially to be hassle-free during an MRI scan. So no head bandage is needed because we offer easy MRI. Also, reliability is really great, and we have already experience with the bone bridge since 2011. So more than 12 years of experience with bone bridge. And if you want to see all the cumulative survival data, I ask you to join our professional homepage because we have the data available there. And with this, I also want to introduce already our guest speaker today. We have Jafri Kuthubutheen from Australia. He has a load of titles, so I won't read all of them, Jafri. I hope that is okay for you. And he is going to talk about his experience with the bone bridge surgery in children who have a complex ear disease like microtia and aural atresia. And with this, I hand over to you, Jafri. Please, the stage is yours.
Thank you very much, Christina, for a kind introduction. I'm very excited to be here and share with you our experience on the bone bridge and hopefully your users and will find some benefit from that. So with that, I'm going to share my screen. Okay, so first of all, I'd like to mention some disclosures We receive electrode support from MED-EL for our cochlear implant research at the University of Western Australia. And we also receive funding from MED-EL for our annual Perth Otology and Temple Bone course, also at CTEC at the University of Western Australia. It's a fabulous facility, and I hope that all of you one day will be able to come and visit. I come from Perth in Western Australia, and for those of you who are unaware, we are in the westernmost tip of the continent. This is the picture of the university, which sits on the bank of the Swan River. It's a really a picturesque venue. I work at 3 of the public hospitals in Perth, at the Queen Elizabeth Medical Centre, Fiona Stanley, and the Perth Children's Hospital, which is the main tertiary referral hospital for the state. And this is where this work that I'll be presenting was conducted. A lot of this work is not of my own sole effort. We have a great program called the Children's Hearing Implant Program at the Perth Children's Hospital. And we're very fortunate to have a team of medical as well as audiologists working with us. So my colleague, Dr. Steve Rodriguez, we have a neurosurgeon, radiologist, geneticist, plastic surgeon, and a really excellent team of audiologists, implant audiologists, speech pathologists, and auditory verbal therapists. So I'm very fortunate to be able to work with such an incredible team. I'd also like to acknowledge the support of Barbara Gill, who's our clinical specialist here in Perth. Robin Shakes, who's our wonderful managing director, who's always so supportive of us. And Dr. Pei To, who's our ENT registrar, who helped compile a lot of the data and the statistics for this talk that I'll be presenting. So first of all, I'd like to give you an overview of what I'll be covering in this session. We'll review the BONEBRIDGE implant. You've already heard a little bit about that from Christina. I'll discuss some of the indications and the workup. I'll review our cohort of patients so you can see the type of patients that we have been implanting. I'll run through the surgical planning and the steps, share with you some of our surgical outcomes, and I'll finish by discussing 3 specific cases that I think illustrate some of the key learnings for this implant, but I hope you find that useful. So you've already heard about the BONEBRIDGE implant. We're now on to our 2nd generation device, so the BCI 602, with the Sambo 2 audio processor. This was launched in 2019-2020. But as you've heard, the 1st generation device, the 601, was launched in 2011. And I was very fortunate to have been able to implant the 2nd BONEBRIDGE in Canada when it was first introduced. There are some differences between the 1st and the 2nd generation device. You can see here on a side-by-side comparison. There have been significant changes made to the dimensions of the new generation. It's significantly shallower in depth, 4.5 millimeters versus 8.7 millimeters. But the diameter is slightly larger, but still maintains a very slim profile. How does this compare? Well, the shallower depth is certainly significantly advantageous. You're less likely to require dural and sigmoid sinus compression or the use of a lifter, and our data certainly supports this. And certainly the lifts that are needed are only 1 millimeter now. A larger diameter means that the mastoid curvature may be more of a consideration. And the actual implant process is significantly simplified. We now have self-drilling screws, and it's much easier to secure the floating mass transducer, which is the vibrating portion of the device, into the bone. So certainly the actual surgical procedure itself is significantly more streamlined. Now, the actual implant itself, as I mentioned, it's a very slim profile. It sits just over 4 millimeters above the bone surface at the point of attachment. It sits flush with the bone, and the receiver coil is only 4.5 millimeters thick. So it's very, very slim indeed. The greatest flexibility, in my opinion, of this implant is its flexibility. The fact that that you can rotate the device up to 90 degrees off rotation in either direction. And what this means is that the overall footprint of the device is significantly smaller. You can also, as you've seen earlier, you can bend the device up to 30 degrees of flexion to account for skull surface variability. And I think it's this flexibility of the implant itself that, in my opinion, is arguably its greatest strength in terms of positioning the device, and particularly in our pediatric patients. So you've already heard of some of the benefits of the bone bridge in children, and I'd like to highlight them again because these can't be overstated. The fact that it's an intact skin solution, both power and sound generation are spatially separate. Patients have immediate access to a full dynamic range. It's a slim, non-vibrating external device. And I'll share with you later, you'll see that you can provide hearing rehabilitation without the need for atresia surgery. It can be combined with Microtia surgery that I'll also share with you as well. And it's suitable for use in complex ears, and particularly when placed in the retrosigmoid location, which has really become our preferred location in a lot of our pediatric patients. These are the audiological indications. It's indicated for conductive hearing loss as well as mixed hearing loss. In Australia, the device is not fully subsidized for single-sided deafness in children, and that's because we tend to prefer the cochlear implant for those indications. In Australia, the current approval age is over 5, and I'd like to term young children as being kids under 10 years of age. This is the bone bridge fitting range. In red are the bone conduction thresholds you can see down to 45 decibels, and obviously the air conduction thresholds are anywhere above that. So as long as you stick within the bone bridge fitting range, then you should be fine. This is our pathway for patients who are potential candidates for the bone bridge. We complete a full otological medical assessment. All patients undergo a full audiological test battery. They get speech pathology assessment. We get a trial fitment with a bone conduction hearing aid as early as possible. All patients get a CT scan of the temporal bones, plus or minus an MRI scan if required. And for patients that do require subsequent plastic surgery, we get a plastic and reconstructive surgery assessment as well. All of our patients have a co-assessment with Hearing Australia, and they are a national provider of hearing aids and bone conduction hearing aids. And so they're involved as well. And all of our patients are discussed at our multidisciplinary meeting. In terms of surgical planning, we assess patients as early as the diagnosis is made. In our center, we start surgical planning around 4 years of age. Where possible for patients, particularly with conductive hearing loss. And that's in order to aim for the bone bridge surgery as soon as possible after the age of 5. And of course, that will certainly vary from patient to patient, depending upon their clinical situation. As I mentioned, a CT scan of the temporal bones is really important to assess for anatomy and mastoid pneumatization. And so you can see here, this patient has atresia, and they have a pneumatization of the mastoid, but there's also a mastoid emissary vein, which will need to be considered. We don't routinely use CT planning software. You've already heard about the use of AutoPlan, and so that option is certainly available as well to use. And where plastic surgery is required, the plastic surgery component is usually delayed until after 10 years of age in our center. So this is our cohort of patients. You can see here, there's a whole range of different ages, difference of, both left and right ears that are implanted, and a wide variety of etiologies, as you can see, which really, I think, illustrate the heterogeneity of our patient population. And I'll go through that in summary following this. So in total, we've implanted 21 patients, 9 who've received the second generation device, and 12 have received the first generation device, with an age range between 5 and 15 years of age. You can see the mean ages there. half of our patients are under 10 years of age. In terms of etiology, by far and away the most common etiology in our cohort are those patients with Microtia and Aural Atresia. Of those, we have 4 patients with Goldenheart Syndrome, 1 patient with a chromosomal duplication. Our next most common are patients with congenital acicular anomalies. Some of them are syndromic, some of them are non-syndromic. And then we also have patients who have other types of ear pathology, such as chronic ear disease, persistent stapedial artery, and idiopathic causes as well. I won't go through Microtia reconstruction and classification, other than just to remind you that that Microtia can be classified. This is the MARCS classification, one of the many classification systems. And you can see here that it's classified based on the degree of pinna anomalies that are present. In terms of our patient cohort, by far and away, the most common type of hearing loss that we have implanted are those children with conductive hearing loss. There are then a small number of patients with sensorineural hearing loss and mixed hearing loss as well. But conductive hearing loss is really our main type of or pattern of hearing loss that we implanted. In terms of the temporal bone imaging findings, as you can see, there's a wide variety, both affecting the outer ear and the mastoid, the middle ear, as well as the inner ear. And so, in our cohort of patients, we have patients who have atresia, who have had a myeloplasty before, who have a sclerotic mastoid. We've had patients who have vesicular pathologies, abnormalities of the facial nerve. And we also have had patients who've had inner ear anomalies involving the oval window and the round window. And so really what this shows is that complex ear anomalies in our cohort of patients is not a contraindication to bone bridge insertion. And that really, I think, highlights, again, the versatility of this implant in our pediatric cohort. So this is an example of some of the radiological findings. This is a 9-year-old boy who has right-sided Microtia. He has bilateral inner ear anomalies with an abnormal oval window and absent stapes, but a well-pneumatized mastoid, as you can see here. This is another one of our patients who have received a bone bridge. This is a 14-year-old patient who has left atresia. You can see that the patient's also had a previous mastoidectomy, a retrosigmoid emissary vein, and so these are some of the findings that even despite this occurring, can still support a bone bridge. And so you can see here again the position of the sigmoid sinus. And an abnormal temporal bone that can, again, as I said, still support a bone bridge implant. This is another example, another one of our patients. This is a 13-year-old boy who has a congenital right-sided facial nerve palsy with bilateral maximal conductive hearing loss. Here you can see the facial nerve running across the oval window with atresia of the oval window with a prominent mastoid. And even in this type of patient, you can still implant a bone bridge. This is a 6-year-old child who has Goldenheart Syndrome with anomalies of the temporal bone and skull base, as well as vesicular pathologies, again with a pneumatized mastoid. So even in these patients with a careful planning and surgery, a bone bridge implant can be inserted. This is an example of where age necessarily isn't a contraindication. This is our youngest recipient. This is a 4.5-year-old boy who has Microtia, and even in this patient, this patient has a well-pneumatized mastoid and can certainly support a bone bridge implant as well. Now, the question, of course, is, will the FMT fit? This is a nice paper that was written by Stefan Plonke's group, showing that the second-generation device, the BCR602, is certainly able to fit a greater proportion of patients. Certainly, the percentage of being able to fit an implant increases with age, as you can see, but the second-generation device takes it to another level. so the concerns about the device fitting, I think can be allayed as you'll see in our experience as well. We briefly covered a surgical planning software. There are a number of options that have been available. You've seen some presented already. In our opinion, we haven't found the need to utilize this. But if you wish to, there are certainly options available, and you've also heard about the Otoplan as well, and how you can upload the CT scan to guide placement of the FMT. So just to run through a bit of a case to illustrate our process of what we do when we see a patient who may be a candidate for a bone bridge implant. So this is an example of a 7-year-old boy. This is the boy seen at our preoperative assessment. He was initially seen by us at the age of 4.5, and he has, as you can see, a right-sided Microtia as well as Atresia, and he was really a consistent user of a bone conduction hearing aid. And now the parents and him want to consider a bone bridge. So in the preoperative assessment, what we do is assess the soft tissue around the pinna and in the mastoid area. We look at the hairline, we look at the position of the mastoid tip, whether they're wearing glasses or hats. So you can see here he wears glasses, and all these things will affect where we plan on inserting the implant. You can see here, I've now retracted his hair back, and so you can see the hairline quite nicely. And in this patient, as I'll show you a bit later as well, this gives us the opportunity to decide where we think the FMT should be. And so in our center, in this patient, we would try and insert the FMT as far back as possible in order to leave this area for our plastic surgeons to perform the reconstruction. We also, as I mentioned earlier, obtain a CT scan of the temporal bones. This will help us to plan the surgery as well in more detail. So here you can see this patient has atresia. They have a well-pneumatized mastoid, and perhaps in the sigmoid area, there's an emissary vein that will need to be taken into consideration. We also look at the position of the facial nerve, any ossicular pathologies, and in some cases, they may even have an EAC cholesteatoma. So that patient may require an MRI scan and addressing that prior to the implant surgery as well. So now I'd like to perhaps run through some of the surgical steps. We'll talk about the incision planning, soft tissue work, and then followed by the bony work that's required for the implant. I'll show you shaping of the implant, insertion of the lifts, and then insertion of the screws, and finally some pointers about wound closure and dressing. So to illustrate this, this is an example of a 14-year-old female who has Mel Duggan Syndrome. This is an autosomal recessive condition characterized by complex craniofacial syndromes with open sutures in multiple locations. She has a stenotic ear canal, a ossicular fixation, and a thin bony cortex that was really deemed unsuitable for a titanium osseointegrated implant. She had a well-pneumatized mastoid, and so we decided to proceed with a left bone bridge implant. This is the preoperative CT scan. So you can see here the anomalous facial nerve. There is a stenotic ear canal and a well-pneumatized mastoid. So first of all, we mark out the position of the skin incision. Even though the mastoid is quite well pneumatized, we've decided to place this implant much more posteriorly. And I think that's just, in our experience, what we tended to do for a lot of these patients, almost as a routine, is to place the implant as posterior as possible. But certainly you could choose to place this more anteriorly if you wish. And this is in case you ever needed to access the ear for any other reason. Once the incision has been marked out, I like to use the template to try and picture where the FMT and where the magnet will be. The patient is then prepped and draped in the usual fashion. We use local anesthetic as well for hemostasis and for analgesia. This patient has obviously had the surgery done under general anesthesia. Once we've made the skin incision, we get into the this soft tissue plane. The point I wanted to make is that this muscular periosteal plane is really continued in the posterior direction, because we really don't want to go anterior and disturb the soft tissue, because that's the plane that our plastic surgeons will be accessing. So as a matter of principle, we do this for almost all of our patients. Once we've done that, I usually make an anteriorly based flap. I find that's quite a nice flap because it allows access to the pocket, which you'll be creating shortly. So once that's done, we've created a pocket. We then mark out the template for the FMT, and you can mark this with a pen or a pencil. And this is the area that we're going to be drilling shortly. So you can see the incision is about as big as you need it to be. It doesn't have to be very small incision. It's got to be enough so that you can drill this safely without catching in any of the soft tissues or the skin in that area. And I think that soft tissue care, I think, is really important, particularly in pediatric cases. Once we've created a well for the FMT, we check the actual with the template to make sure that it fits. And after that, we're ready for the implant. I'll show you shortly how the lifts are used. So the lifts come packaged like this. With the second generation device, things are significantly simplified. So there's now just a 1 millimeter lift and screws that come with the kit as well. So this is a video showing the shaping of the implant. So here we've already drilled the well. I'm trying to determine where the best place is to put the magnet and how to shape it. And so now you can see here, with some gentle pressure, you can bend the implant into the place that you want it to be. Okay. What we then do is, if you decide to use a lift, then that would be the next step. So here, we're taking the lifts out, and these just really add just that extra height to the implant, so that you don't have to decompress any more than you want to. And so they clip on very nicely, like so. It's best to often do this outside the wound before you put the implant in. It's much easier to do that. Okay, and so they just add just that extra height that's required. So now, once we've done that, we've decided on where the implant is going to go. The next step is to then insert the bone bridge into the periosteal pocket. So here we're lifting up the skin, and it should slide in. And we've already, as you can see here, we've already decided where to bend the FMT. The lifts are on, and hopefully this should just click into place. Another tip also is that you have to make sure that the soft tissues don't catch. You can see here the flap is getting caught, so we move that out of the way and it clicks in. Okay. Right. So the next step is to secure the implant to the bone, and as I mentioned earlier, with the new generation device, or the second generation, there are self drilling screws that are available, and so they come as the standard screw. There is an emergency screw which is in blue. In case the first screw doesn't take, you can use the emergency screw, which is slightly wider. So here we remove the cap of the screw. The screwdriver comes with the kit, so you don't have to look for your own screwdriver. Now, once you've loaded that, the next thing is to insert the screws into the bone bridge. It's important to make sure that the screws are perpendicular. And so here we're just doing the final tightening of the screw. It's important to make sure that it's finger tight, and obviously don't over tighten. In the previous generation, you had to use a torque wrench but you don't have to do that anymore. It's just a finger type. So again, a very simple, simplified insertion. And so finally, once that's done, then comes the soft tissue closure. And I think it's really important to make sure that you cover the metalwork. You can see here the anteriorly based flapper is really well preserved. And so here you can see we're now closing over the implant. And if you look after the flap and you've raised a nice flap, you can get a good 2-layer closure, which again is really important for any implant. And I think is something that can usually be achieved in the vast majority of cases. Great. And so once that's done, we use dissolving sutures. Obviously, in children, we don't want to be using sutures that need removal. You can then place some steri strips over the top. Patients then have a head bandage. They usually stay in hospital for 1 night. And then they go home the next day. After the surgery, I'd like to do a bit of a debrief, just check that we've inserted the implant where it should be. You can usually have a feel of the magnet as well to make sure that that the implant is in the final position as you'd expect it to be. Now, in terms of placement of the FMT, so this is just to illustrate where the FMT was placed with the first generation device versus the second generation. So you can see that in the first generation, a lot of our patients had the FMT placed in the mastoid part, and we had a smaller number who had it inserted in the retrosigmoid area. Whereas in the new generation device, we shifted to a more retrosigmoid placement that allowed us to place the device more posteriorly, and I guess that was our practice. And you can see in the second generation device, the majority of our patients are now have the FMT placed in the retrosigmoid area, and I think that's just a reflection of the types of patients that we have been seeing. Now, in terms of the sigmoid sinus and Jura, so in the first generation device, you can see that this is showing the sigmoid and the Jura not being exposed. With the new generation device, you can see that we are perhaps exposing a bit more of the sigmoid and perhaps similar amount of the Jura, but because we're going into a retrosigmoid placement, there's perhaps a little bit more of a dural decompression than we are with the first generation device, but the sigmoid is less exposed, and I think this reflects the shift in placement in our hands from the first generation to the second generation device. There have been a number of centers that have published on the effect of dural and sigmoid sinus decompression or exposure and haven't found any detrimental effects, and certainly in our center we haven't had any issues with dural decompression, and you can certainly minimize that even further by placing lifts as well. In terms of the types of screws and the lifts, so you can see here with the first generation device, there was a range of different screws that we're using because we had a range of different lifts that we were using. In the first generation device, you had up to a 4mm lift. And when you use a much larger lift, you need a longer screw. And so you can see that that was the case with the first generation. But with the newer generation device, where the implant profile is significantly smaller, you can see that the surgical technique has also become more uniform as well. We're using self-drilling screws in almost all of the cases, and we're using now only a 1mm lift kit, and in some cases you may not even need a lift as well. So so I think the second generation device has certainly simplified the surgical technique considerably. You don't necessarily have to use a lift on both sides. You can use the lift on either wing of the FMT, depending upon the curvature of the patient's bone. So, for example, if there is an uneven mastoid cortex curvature, you can use a lift. You can of course choose to drill away the bone and recess this. But we find that it's just as easy to insert a lift on one side. And similarly, if there is an uneven sigmoid sinus or dural position, you can use an asymmetrical lift to help position the implant. So this gives you a further flexibility in terms of the placement of the implant. These are some of our complications that we've encountered with both devices. So with the BCI 601, we had one patient who had sigmoid sinus bleeding intraoperatively that resolved with a muscle and spongistan. We had one patient that required bone cement to anchor one of the screws, and I'll come to that in the case discussion. Postoperatively, we had one patient with hemotympanum, one patient with pain around the implant site. And we had one patient who had blunt trauma after the surgery that had to have the implant explanted and then reimplanted. And I'll also cover that in our case discussion after that. With the second generation device, we've had no intraoperative complications. We had one patient postoperatively that had swelling around day 6 after surgery, and that resolved. And these patients have been using the implant well without any issues. So in terms of the postoperative appearances, this is an example of a boy who received an implant. He's 10 years of age. This is now 6 months post a bone bridge insertion in the right ear. As you can see, he has right-sided microtia with bilateral inner ear and middle ear anomalies. He had surgery in June of last year. You can see the incision is just within the hairline. And as I mentioned earlier, for these types of patients, it's really important not to disturb this anterior skin, particularly in that muscular periosteal plane, because that's a plane that our plastic surgeons are going to be doing when they come to performing reconstructive surgery of the pinna. This patient has the sound pressors are on. You can see here. This patient also wears a hat, and so you can use a hat over that if you wish as well. This is another one of our patients postoperatively. This is a 6-year-old girl with a bilateral microtia, Aural Atresia. She had surgery in July last year. This is her 7-month follow-up. You can see that her hairline is perhaps not as far set back, but we did make the incision much further back, again to allow for future reconstruction of the pinna. And she's really happy with the device, and she now wants to consider a right bone bridge implant. So you can see here, this is a side view showing the placement of the Samba audio processor. So I just wanted to share with you a video of parents' sort of feedback, and I hope that you will find this useful. Okay, so can you tell us?
So it's like, since having this particular device, her reading, her concentration, just her overall class results and levels have just gone like shot up through the roof.
And how is it different to the headband device that she was wearing before?
So she was wearing both on each side. Mm-hmm. They would unclip really easily if they were touched by even her shoulders if she was on the monkey bars. Mm-hmm. But also that connection would be lost through the hair. Mm-hmm. So if her hair was between the hearing aid, there wouldn't be as good of, what do you call it, sound, I suppose. Mm-hmm. Whereas this one she can put on herself, so the independence is like, her independence has gone from needing me to put, to hear, to now she just, even like, if her brothers are being too loud, she would just take it off. And I'm like, oh, I wish I could do that.
And you said she wears a helmet for when she goes riding?
She wears a helmet for riding, so she rides horses. And previously we had to take her Baha hearing aid headband off because it would make that interference sound, or they would click off and fall off her. So she's been able to ride her horse and not have that issue with writing and not hearing the instructor, which is pretty important.
Excellent.
But yeah, no, her teachers have said that since receiving it, they've just noticed a huge difference.
Great.
Like her levels of reading have gone up, her concentration in class has gone up. It's, yeah, they're very impressed with it.
Great.
Yeah.
Excellent. Well, thanks for sharing that with us.
No worries.
That's such honest and wonderful feedback, and it's really nice to hear that, particularly as a surgeon, because you know, these are things which which may be small to us, but make a huge difference to patients. And so you've heard Mum talking about more consistent access to sound, improvements to speech and language development, the secure magnet attachment, the fact that she's an independent child and she takes charge of her own hearing. And I mean, that's a big positive. And as you heard, I mean, she rides horses and she wears a helmet. And so even in an active child, the implant works really well. So that's really nice to hear. In terms of the aided bone bridge thresholds, you can see here, this is in our data from our patients with conductive hearing loss. They really get very good high frequency performance, all the way up to 8,000 hertz. And this is accessible from very early on, and as you know, is independent of soft tissue and skin thickness. So this is really the benefit, I think, of the implant. I'd like to finish off by sharing some specific lessons, in particular 3 cases. So the first is our youngest recipient, a 4.5-year-old. The second is a failed insertion of an osseointegrated titanium implant in a well-pneumatized mastoid. And the third case was a bone bridge explant and reimplant. This is our youngest recipient, Tate. Tate is 4.5 years old, and his challenge was that he had conductive hearing loss in his only hearing ear. So he has on the right side a dead ear due to a malformed cochlea and an absent cochlear nerve. And on the left, he has a microtia with a left-sided conductive hearing loss and a normal cochlear reserve. And he received the 601, BCI 601. He was a long-term bone conduction hearing aid user, but due to poor compliance, and his only hearing ear being a conductive hearing loss, the cochlear reserve could not be reliably accessed. And because of that, he was nonverbal, and his parents almost resigned him to being nonverbal. This is the CT scan, which I showed you earlier. So you can see even in a young child under 5 years of age, in some cases, there is space to put the bone bridge, and this is even with the 1st generation device. So certainly with the 2nd generation, this would not be an issue at all. And he's done really well. Preoperatively, we were unable to assess his speech outcomes. Postoperatively, we could perform aided closed set testing. And this is a video of again Tate's parents. They're giving you some feedback about the implant.
And will you hold it then? And it's like only hearing a jumbo jet. You need it to be very loud around him, which he is now.
He hasn't said dad properly until about 3 months ago. But he's been really quiet, hadn't talked, and we're trying to understand what he's trying to tell us. And just makes it a lot harder for us compared to other little kids when they're talking when they're 7, 8 months old.
When they first activated, he was like a stunned mullet. He was very, he went from being very quiet to frozen, and then, oh wow, what's this around me, looking around and having a real good time. Yeah, to actually hear your son's voice and clear is the best bit. Hearing mum being, his favourite word at the moment is thank you. And it's just, how would you say it? He's really coming out of his shell. So it's a big, I guess you'd say, by turning it on, it's enlightened everything.
Great, that's so good to see. This is Tate's picture questionnaire scores, and you can see that after the BONEBRIDGE implant, he's getting scores at the expected value of normal hearing, even better than the soft band or the bone conduction hearing aid. This is our second patient. This is a child with Goldenheart Syndrome who's 7 years of age, and this child had Microtia as well as a conductive hearing loss. And this is a very interesting case where we attempted a bone-anchored implant, but we couldn't proceed because of the cortical bone thickness was too thin. It was between 2 to 3 millimeters. And the bone quality was also somewhat abnormal as well, and wouldn't support a titanium implant. You can see here the attempt at putting an implant in, which just didn't support the implant intraoperatively. Because the child had a well-pneumatized mastoid, we found that a BONEBRIDGE was actually the more suitable implant. In one of the screws, however, we did require some hydroxyapatite bone cement to reinforce the screw because of the concerns around the bone quality, and this child had a successful placement. And finally, a third case. This is an 11-year-old boy who had a BCI 601 implanted in August 2019 for congenital aceticular chain anomalies. Unfortunately, he had an assault to the head just over a year later, which unfortunately resulted in failure of the implant. We then decided to proceed with explantation and reimplantation, but because the second generation device, the BCI 602, was now available, we decided to insert the new generation device. So here you can see the implant. This is the 601. We've gone through the same postauricular incision. We've exposed the FMT. There's usually some soft tissue scarring around the implant, which we expose. And here we've exposed the rest of the implant and loosened it from its periosteal pocket. We have already removed one of the screws. This is removing the other screw, and the implant can very easily come out. As you've heard, these screws are not osseointegrated, so you can remove the screws. And this, you can see here, this is the previous well that we've drilled, and the periosteal pocket. We then have the new BCI 602 in place. And here we are measuring the template for the FMT. There is some drilling that's required to widen the recess, as you know, but in terms of the depth, we don't need to make that any deeper because the new generation device is significantly shallower. Once you've the implant has been bent into shape to where you want it to be, it can simply be reinserted. And it's a straightforward exchange. Here you can see that we've had to change slightly the position of where the screws are inserted. You can see here these are the original pilot holes that are there from the first generation device, and so we've just slightly rotated the FMT clockwise. And then inserted it with some self-drilling screws. And because we're using self-drilling screws, as I mentioned, it simplified the implant securing process tremendously. And as I mentioned, the same soft tissue pocket can also be used as well. And so to finish off, I just want to share with you some of our experience with ear reconstruction post BONEBRIDGE implantation. So we've had 4 patients so far in our cohort that have gone on to Microtia surgery. We've had 1 patient who completed stage 3. He was 9 years of age when we inserted the BCI 601, and then and sometime after that, he's gone on to have 3 stages of microtia surgery, the most recent being lobule repositioning, and elevation of the pinna with a full thickness skin graft. We've had 2 patients complete stage 2, and we have 1 patient who's completed stage 1 as well. And what's important to note is that in none of these patients were the BoneBridge implant exposed during the surgery, and there were no BoneBridge complications. And in fact, our plastic surgeons who were initially a little bit apprehensive, have become very comfortable working in this area with the BoneBridge implant, and they don't even call me into theatre anymore. They just tell me, they're going to be doing the surgery, and I say, yep, go ahead, and then they proceed accordingly. This is our first, one of the patients that I just mentioned earlier. So this is a patient who has microtia, and this is after his BoneBridge implant surgery. You can see we've made that post-auricular incision quite a distance away from where the pinna is, and this is the patient now after stage 3 of microtia surgery with the BoneBridge in situ, and you can see that it shows that you can perform microtia reconstructive surgery even in the setting of a BoneBridge implant. So to summarize, the BoneBridge, it really is a versatile implant in children, even with complex temporal bone anomalies. In our experience, the retro-sigmoid placement avoids accessing the mastoid, decompressing the sigmoid sinus, and is, I think, really widely applicable to a lot of our pediatric patients. As you've seen, it's suitable for patients who are undergoing staged microtia surgery. And you've heard that it's an implant that's really well received by patients and their families with minimal complications and a very secure off-the-ear attachment. So once again, I would like to thank all of my colleagues at the Children's Hearing Implant Program in Perth in Western Australia. And for those of you who are interested, my colleague and I are hosting our annual National ENT Scientific Meeting in Perth in March of next year. And so I invite you all to come and visit us, and hopefully it will be a nice time of the year to visit as well. So thank you very much for listening, and thank you, Christina, for having me.
Well, thank you very much for this really nice and informative presentation. I personally really like the patient interview when you see that the child is really doing well with the BoneBridge afterwards. But yes. I guess most of our presenters or most of our people attending were more interested in the fact that you do pinna reconstruction after you do BoneBridge. Have you ever done also a BoneBridge while doing a pinna reconstruction so that you work together with your plastic surgeon?
We haven't done it simultaneously. I mean, it is a thought. I guess in our experience, it's a relationship that is evolving. So initially, in my first BoneBridge surgery in our patients who have microtia, I actually had the plastic surgeon come into theatre with me, and I said, this is where I want to make the incision. Are you okay with that? Is that going to interfere with what you're doing? So, so initially there was a lot of that discussion that was happening, and now, I just tell them, what, we've got this patient coming up. Just letting you know, we're going ahead, and we just proceed. And so there's that trust there. And as I mentioned earlier, when it came to their surgery, initially they were very concerned about exposing the implant, and what are they going to do, what happens if they damage the implant. And so initially I came in again to the surgery with them, and I just stood around, and they proceeded, and after a while they were comfortable, and I didn't have to be there. So perhaps the next evolution is simultaneous. I'm not sure we're there yet. I think, and that's part of the reason is because in some patients, we like to implant them quite early. And our implant surgeons, our plastic surgeons like to reconstruct much later. So I think we're still going to have that split. But maybe for the older child, like, who are, 9 or 10 years of age, where they want to have both done, maybe that's an option in the future.
Could you summarize for those who want to start doing bone bridge together with the pin reconstruction? Could you summarize what are the most important steps when you do a bone bridge surgery if you know that later on pin reconstruction is planned?
Yeah. So I think the first thing is to have a discussion with the plastic surgeon, because your idea of where the incision will be very different to what they want it to be. And I found that my plastic surgeon wanted me to have the incision much more posterior than I would like it to be. So it really forced me to go, as posterior as possible. And so we agreed on, on the hairline. So I think the first thing is be prepared to change your incision to suit your plastic surgery colleagues, or if you don't have a plastic surgery colleague that you can communicate with, place the incision as far posteriorly as possible. Because even if you do, especially with the BCI 602, it is possible to place the implant in the retrosigmoid area, and you might need to use a lift, and then that's fine. And then don't be afraid of encountering the sigmoid or the Jura. The implant is really designed to fit a wide variety of cases. And if you are concerned, use the Otoplan software as you've shown, just to pick a position, and then do the procedure as you normally would. And as I said, with the flexibility of the device, you can be fairly confident that you'll find a place for the implant. It'll fit. So even in patients with a difficult anatomy. So that would be my main messages.
So most important is stay away from the retrosigmoid from the area right behind the ear, and go a little bit further posteriorly with the incision, so that the site where you plan pin reconstruction is untouched, right?
Absolutely, definitely right.
Perfect. Well, then let's have a look if there's more questions in the chat. And there was one: what transducer did you use to measure air conduction thresholds?
Good question. So I guess it depends on the patient. The patients that had an ear canal, or even a small ear canal, you can try and get air conduction thresholds. In patients who have middle ear ossicular anomalies that have a patent ear canal, obviously you can measure air conduction thresholds that way. But obviously in patients who have no ear canal, then obviously you can't measure air conduction. So it really only applies to those patients where you can access the ear canal. And as I mentioned, not all patients have no ear canal. There are patients who do.
Another question is whether you have any experience in secondary cholesteatoma after bone bridge surgery.
A good question. I haven't. As you may have heard me present earlier, a part of the workup is really important. So in the beginning, you can have, I wouldn't say maybe primary, but I wouldn't say secondary, but maybe primary cholesteatoma. I have seen a patient with a stenotic ear canal and essentially a cholesteatoma in the ear canal, and so that will need to be managed before you put the bone bridge in. I personally haven't come across any cholesteatoma after the bone bridge. You saw me present. There was one patient who had previous canal wall down mastoid surgery, who had a bone bridge. In those patients, you really have to make sure that there is no cholesteatoma remaining, and so you have to determine that clinically, as well as on MRI. We do an MRI with diffusion restriction to really make sure that that you're not you're not missing any cholecystoma, because once the implant's in, obviously you don't want to have to do any unnecessary surgery.
Another question, a 3-year-old child with Goldenheart syndrome and profound bilateral hearing loss, and he didn't benefit from the headband hearing aids. What is the expectation to benefit from a bone conduction implant?
Does that patient have purely a conductive hearing loss?
I don't know.
I don't know.
So if it would be purely conductive, what would happen?
Yeah. So let's assume they have purely conductive hearing loss, and the question is that they're not benefiting from the bone conduction hearing aid. Is that the question? I
yeah, they are not benefiting from the headband.
Yeah.
And now the question is, would they benefit from a bone conduction implant?
Well, the thing is that I guess it depends on a lot of things. It depends on how the bone conduction headband was being applied, how is it being programmed, how often they're using it. All those things really determine the success of the bone conduction headband. In our experience, in the vast majority of patients, particularly the ones that do get benefit from it, they love the bone conduction headband. Until they can get a bone bridge, because they completely rely on it. So it would be unusual that a patient wouldn't get any benefit unless there was some other reason. But you've seen from the video that there are issues with the headband. It's inconsistent, it falls off, there's interference. And all of those things can make it a subpar experience for the child. And so is it because the child is not enjoying that, or is it because the headband is just not working very well? So I would still, I think, consider them potentially for an implant, because you can see that with the bone bridge, it's a much more consistent sound and consistent signal that you're getting. So I wouldn't completely exclude them. And sometimes you have to test these children and the older they get. The bone bridge is approved for children over the age of 5. So I would keep seeing them. I would keep testing them until they're 5 years of age before you say, for sure that they're not a candidate. So I wouldn't give up so easily.
I have one final question. You mentioned that you had a patient where you wanted to insert an osseointegrated bone implant, and it didn't hold because the cortical bone was too thin. And after you put the bone bridge in, how did you fix it? You mentioned you used some Bombardier.
Yeah.
It was the first generation, right? So you had to pre-drill holes.
That's a very good point that you brought up. So yes, so because it was a first generation device, you had to pre-drill and then you have to use the screw. So it's 2 steps. And so there is a risk that when the bone quality is not so good, that it's just harder to secure the implant. So we managed to do that quite easily for one of them, but for the second kind of screw, it did take, but it just didn't feel as tight as we would like it to. I think we didn't get to the 20 newton meters of torque, I think it was, that you would have to use. And so we reinforced, we reinforced underneath, I guess, because it was actually into the air cell. We reinforced it underneath it with bone cement, just to be sure. But I suspect that with the 6 or 2, that problem may have been avoided.
I guess so also, but
maybe
I can't be 100% sure.
maybe. But it's just one less thing, one less step to secure the implant. But that was a really unusual case. I've never come across that again. Hopefully not ever again, thankfully. It shows that sometimes you have to think outside the box a little bit.
And there's one final question. Doesn't the device capture too much noise from the back if the implant is positioned further posteriorly?
It's a good point. I think it looks on the screen like it's really far back, but when you look at these patients, it's really on their side. And when we make sure that when they're lying supine, that when they turn their heads, that they don't knock it. We haven't really had that issue. I must say I'm not fully up to date with the directional microphones on the Samba, but I would suspect that they would be able to account for that placement.
Yes.
We haven't really seen any issues with that.
And if there's no pinna reconstruction planned, would you put it further anteriorly, or would you say the child at a later stage might want to have a pinna reconstruction even though parents don't want to have one?
You know, personally, I would rather keep all the options open. You know, there are, and so I wouldn't take that option away from the child. So if I can place it as far back as possible, and if the parents are okay with that, then I'll place it there. And that's why that's become kind of our standard. But you know, at your center, you may choose differently, and you may choose to put it in the mastoid. As long as you are clear about what the overall understanding is, that's the most important thing.
I think that's a very good thing to close this session. Thank you very much. And it was very interesting. And I guess you go to bed now because it is already quite late in Australia.
That's okay. No, it's a nice winter's night here.
Thank you so much. We really enjoyed listening to you and wish you all the best. And I just want to mention the next Surgery Online will come back on October 4th, and we have a summer break, so we will see each other again a little bit later this year. Thank you so much for joining us.
Christina.
Bye.
Bye.